SSEPs, the nuts and bolts of somatosensory evoked potentials. Of course, we need to practice by a proper policy and procedure. Make sure everybody's on board with the same policy and make sure the policy is signed by everyone in your practice. Somatosenses are sensory systems that facilitate sensation of touch, pressure, pain, temperature, and vibration to the brain. Somatosensory evoked potentials are time-locked responses along the medial dorsal ascending pathway in response to a stimulus of a peripheral nerve. SSEPs provide information from the central nervous system, which is the brain and spinal cord, and the peripheral nervous system. The SSEP pathway conducts at 58 meters per second. A little bit of brief anatomy with respect to somatosensory evoked potential pathway. The spinal cord runs from C1 down to T12, from the brainstem where it terminates to the conus medullaris, right here. It consists of white matter, and it's white because the nerve fibers are encapsulated by myelin, and it has a white appearance. These are the spinal tracts that convey information to and from the brain. These are the sensory and the motor tracts. A central nervous system neuron is myelinated by oligodendrocytes. These cells can myelinate several cells at once. Here you have the dendrites taking in the action potential. It's being conducted up the axon to the cell body, and the myelin is produced by oligodendrocytes in the central nervous system, which is the brain and the spinal cord. The peripheral nervous system neurons are myelinated by Schwann cells. These myelinate on a 1-to-1 ratio. Again, here's the dendrite, here's the axon, conducts up to the cell body. The myelin sheath is produced by Schwann cells in the peripheral nervous system. The sensory pathways are also referred to as the afferent pathway, the posterior columns, the dorsal columns, the ascending pathway also. Where we get our SSEP information is from the dorsal medial pathway. It's also called the lemniscal pathway. This gives us information about proprioception, vibration, and deep pain. Proprioception is simply if I ask you to stand there with your eyes closed and tell you to touch your nose, you know exactly where to go to find it. Again, this is our SSEP pathway. It's not the only sensory pathway, however. There are others. Specifically, there's the spinothalamic tract. It's more anterior lateral. This is responsible for pain, crude touch, and temperature. These fibers originate in the periphery, they reach the cord, and then they immediately decussate. Then they ascend contralaterally up to the medulla. The dorsal medial pathway enters the cord and ascends up ipsilaterally before it gets to the medulla, and then it crosses over at the medulla. So let's start in the peripheral nervous system. Let's talk about the SSEP pathway. It originates at a nerve that we stimulate either in the arm or the leg. Here's the upper extremity, and here's the lower extremity. Stimulation evokes an action potential. It excites the nerve. This action potential ascends up to the spinal cord through this dorsal root ganglion right here. If it's upper extremity stimulation, we have an electrode placed in the shoulder area or the brachial plexus area. If it's a lower extremity stimulation, we have electrodes placed in the popliteal fossa area. Both of these are peripheral responses, and they're recorded before you get to the spinal cord. The purpose of these, mainly for us as technologists, is to validate that your machine's working. And we'll talk about other purposes of this as well. But one of the main things is to validate stimulation. So if you start seeing changes in your data, but this peripheral response does not change, then you know everything out here, machine-wise, is working correctly. And then you can quickly go to other things to try to troubleshoot. We're going to be stimulating in the periphery, let's say a median or ulnar nerve in the upper extremity. The action potential conducts up through the dorsal root ganglion and ascends to the cord. In upper SSEP, the fibers are called fasciculus cuneatus. If we're stimulating a nerve in the leg, the action potential conducts up through the dorsal root ganglion, The fibers are more medial, and they're called the fasciculus gracilis. This is responsible for the lower SSEP, and the fasciculus cuneatus is responsible for the upper SSEP. And the way I remember that is if you're standing at attention and your arms are down by your side, your arms are lateral, they're more outside, and your legs are medial and they're more inside. Also, the way I remember fasciculus gracilis is grace. The word grace is in there. If you're not graceful, your legs are clumsy. That's the way I remember gracilis. So the fasciculus gracilis gives rise to the lower SSEP. The fasciculus cuneatus gives rise to the upper SSEP. The fasciculus cuneatus is more lateral, and the fasciculus gracilis is more medial. Here's another picture pretty much saying the same thing. We're stimulating out in the periphery. The action potential conducts up. It comes here through the dorsal root ganglion, enters the cord. If you're stimulating an arm, the fibers are the fasciculus cuneatus. If you're stimulating a leg, the fibers are the fasciculus gracilis. They ascend up the cord ipsilaterally to the medulla. Another picture, here's the lower extremity stimulation, upper extremity stimulation. The action potential goes to the cord through the dorsal root ganglion, ascends up ipsilaterally to the medulla. Then these fibers synapse right here at the medulla, and then they cross over. The crossover fibers are called internal arcuate fibers. After they cross over, they ascend up as the medial lemniscus to the internal capsule, where they synapse at the ventral posterior lateral nucleus. The internal capsule is a passageway for all spinal tracts, so motor and sensory fibers pass through here. After it synapses in the internal capsule, it projects out to the sensory cortex. The upper SSEP, or the fasciculus cuneatus pathway, is the purple right here. It projects out more laterally. We have electrodes right there ready to pick up that response. If it's a lower SSEP after the synapse, it projects more medially. I'm going to briefly talk about spinal cord perfusion. The posterior 1/3 portion of the spinal cord is perfused by the posterior spinal arteries. And then the anterior 2/3 portion of the cord is perfused by the anterior spinal artery. Here's the fasciculus cuneatus. Here's the fasciculus gracilis, the right side, the left side. So we know that the posterior spinal arteries are important to the somatosensory evoked potential. As you ascend down the cord, here you have the posterior spinal arteries perfusing the back of the cord, and the anterior spinal artery perfusing the front of the cord. But as you get to the lower portion of the cord and the lumbar spine, this is perfused by the artery of Adamkiewicz. It enters on the left side on 70 to 75% of us. It also branches from the aorta. We could spend a whole day talking about the circle of Willis, but for the purpose of somatosensory evoked potential, we're going to talk about the middle cerebral artery. As you can see here, the middle cerebral artery perfuses the area where we pick up the cortical responses on the upper and lower SSEP. Here's our electrodes. So we're going to be monitoring cases as well, not just spine, but cases that place that middle cerebral artery at risk. It'll give us a world of information if something happens and you got an ischemic event to the cortex. Pre-existing conditions. We need to be able to get into the chart and recognize signs and syndromes and disease entities in order to figure out how the day is going to start. This is a case that I did. This is the left side and this is the right side SSEP. We've got a peripheral response here at the popliteal fossa, but really nothing else after that. Getting into the chart is important. You want to be able to recognize some of these signs and syndromes so you know what you're in store for before you sit down to get your baselines. For instance, with respect to somatosensory evoked potentials, if you see in the chart that the patient has a positive Lermite sign or Lermite sign, I've heard it pronounced both ways. Some people call it a barber chair effect. You have the patient bend their head forward, chin to chest. just like you would see a barber would do to a person's head when they want to cut the back of their hair. If they experience electrical shocks down the arms, then there might be an indication that there's a miscommunication of the nerves that's caused by demyelination. And you'll see this in multiple sclerosis, trauma, radiation myelopathy, B12 deficiencies, and also cervical cord compression. This is a sign that the posterior columns are compromised. Brown-Séquard syndrome. This is a penetrating injury that causes a hemisection of the spinal cord. So half of the spinal cord has been injured, and sometimes you'll see this in trauma or knife wounds or impalement. If you see this in the chart, know that you're going to have an ipsilateral loss of motor function, but you're also going to have a contralateral loss of sensory function below the level of injury. I also want to talk about the Romberg test. This is where you have somebody stand, you have them close their eyes, and you push on their chest or you push on their back, and they should be able to maintain that stance. If they have an exaggerated response to that, let's say they fall forward or they fall backwards, that's a positive test. That's also an indication there's something going on with the posterior columns, and we know the posterior columns, that's where the SSEP is generated, so we may have a problem with the SSEP. Sometimes we see this with Parkinson's patients. Just a few different types of diseases, if you see in the chart that you know you're going to have problems with your SSEPs. One of them is multiple sclerosis. This is a destruction of those oligodendrocytes. And we know those oligodendrocytes myelinate the central nervous system. So it's a problem with the central nervous system. We may have a normal peripheral response, but the responses above that are going to be delayed because everything else is in the central nervous system. Marie-Charcot tooth. This is a destruction of Schwann cells, and we know the Schwann cells produce the myelin in the peripheral nervous system. It's a progressive, inherited neurological disorder, and it usually presents in the lower extremity first. You will see problems with motor and sensory in these patients, which means you're going to have a problem with your SSEP. It's a progressive peripheral nerve problems, so that peripheral response will be affected as well as all the responses following. Peripheral neuropathy, this is a deterioration of the nerves in the periphery. It's often caused by diabetes, peripheral artery disease, arterial sclerosis, alcoholism, and also chemotherapy. It's a problem with the peripheral nervous system. So you're going to have problems collecting all of your SSEPs. So don't only look for peripheral neuropathy in the chart. If you see any of these other diagnoses like diabetes, peripheral artery disease, etc., then you know you may have problems with your SSEPs. We talked about Parkinson's a little bit, but it's a degenerative disease that impairs motor skills. You'll see patients have a decreased speech or shaky speech, and their motor system is affected. It's chronic. It's usually not fatal. And it's caused by loss of dopamine, which causes the nerve cells to misfire. It's a problem in the central nervous system. So we will see SSEP changes, sometimes normal peripheral responses, but once it enters the central nervous system, after that peripheral response, then we may see changes. So my point is, this isn't all of them, but this is a sample of signs and syndromes and diseases to look for before you sit down to do your baselines. For instance, this patient had MS. I got a peripheral response, but not much afterwards. This comes from the peripheral nervous system, and the rest following comes from the central nervous system. And we know MS is a central nervous system disease, so you would expect to possibly see this peripheral response and nothing after. There's the left side and the right side, and basically nothing that reproduces after that. Guidelines and position statements. I had you guys download all of these for a reason. You're going to be needing to study these along your way, and you're also going to be needing to study them for your CNIM exam. ASSET puts out national competencies and skills standards for performing evoked potentials, specifically SSEPs. The ASNM specifically has a position statement on intraoperative neurophysiological monitoring using somatosensory evoked potentials. This is a really good one. It's a comprehensive position statement. The ACNS has several guidelines and statements. Guideline 9A is the guidelines on evoked potentials. Now, these are for clinical evoked potentials. It's important to study these as well because it gives you good machine characteristics that you're going to need to know about. Guideline 11B is recommended standards for intraoperative monitoring of somatosensory evoked potentials. It starts out talking about spinal cord risk in certain surgeries. The risk of neurological deficit resulting from spinal cord damage is about 0.5 to 1.5% in cases for instrumentation for scoliosis. In cases of surgical decompression for spinal cord tumor or trauma, the risk increases of 20%. And surgeries on the descending thoracic aorta exposes patients to the highest risk of injury to the spinal cord, with incidence of paraplegia approaching 40%. This is the reason why we're there. The guidelines go on to talk about us being able to detect peripheral nerve and brachial plexus ischemia due to malpositioning in surgery. Our SSEPs can guide them. Since the patient's asleep and they can't tell us that their arm's numb or falling asleep. We can also assist the surgeon in determining where the sensory versus the motor cortex is in craniotomy type surgeries where a tumor might distort the patient's anatomy. This is a somatosensory evoked potential. These are all cortical responses. There are 6 of them. And you can see where the polarity reverses right here, and they're pointing toward each other. This is an electrode that we place on the scalp. They have 6 contacts, and they correlate to all of these cortical responses right here. So we stimulate, and you see when that polarity reverses, like on the slide I just showed you, that's when you're crossing over into the motor pathways. So this is sensory, 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 sensory. Then you have a phase reversal on that SSEP, and that's where they cross over into the motor cortex. Guideline 11B also talks about preservations of SSEP, where it doesn't guarantee preservation of motor function. So long story short, there have been cases reported with paraplegia when the patient wakes up, but the SSEPs did not change. So it's recommended to also, when the cord is at risk, to do motor evoked potentials as well. 11B also recommends that in spinal cord surgeries above C6 level, we should monitor the median nerve, SSEP. We should do ulnar nerve SSEP with surgeries that involve the lower cervical segments but above C8. Anything below C8 segment, we should be doing posterior tibial nerve or common perineal nerve stimulation. The guidelines don't mention saphenous nerve, so I thought I would mention it here because we're doing this more and more. An XLIF or a DLIF, extreme lateral interbody fusion or direct lateral interbody fusion, it's the same thing. The approach is where the patient is laying on their side. They make the incision and then they retract the psoas muscle. The saphenous nerve is an extension of the femoral nerve, and an injury to the femoral nerve can occur when they're retracting in here, the psoas muscle. So we stimulate here at the saphenous nerve and we record this pathway through this plexus here and record saphenous nerve SSEPs to make sure those retractors aren't injuring that nerve. SSEPs are most often used, though, during spine surgery where the spinal cord is at risk, specifically the dorsal cord. This would be fusions, tumors, trauma, degenerative disc disease, kyphoplasty, scoliosis, and many, many more types. So anytime the spinal cord is at risk, we're going to be doing somatosensory evoked potentials. Collision monitoring. I'm going to briefly discuss this here. Somatosensory evoked potential collision monitoring. We're now being asked to assist in surgery when they place these spinal cord stimulators. These are done after all other measures are exhausted, like steroid treatments, spinal fusions, and the patient still has intractable back pain or leg pain, or arm pain for that matter. The spinal cord stimulator is implanted and it puts off an antidromic signal. Antidromic means the opposite way of the way it's supposed to go. We stimulate at the ankle and that produces orthodromic signal. Orthodromic means in the normal direction. And if we do it at the same time, because they're on the same path, these signals collide. When these signals collide, it blocks the SSEP and we cannot record the SSEP. That's called a collision study. If this is the case, we know the spinal cord stimulator is in the correct place. This is what one might look like. We do EMG over here, and we do the SSEPs over here. You can see the blue is the baseline, beautiful baselines there. We turn the stimulator on. That's what all this noise is the stimulator turning on. So it validates that it is on. And you can see the red here on this side and the black here on this side. It just, boom, those responses go away. The spinal cord stimulator and the SSEP collide, and the SSEP goes away. And this is how it blocks the pain. If the spinal cord stimulator blocks that SSEP, it blocks that signal to the brain that tells you that something hurts. And then they turn the stimulator off, and then boom, these responses come back. So these are kind of fun. They're pretty interactive cases, and you can be pretty helpful to the surgeon during these cases. Now we're going to talk about the hookup. Let's do recording electrodes first. We're going to mostly use needles in the OR. In fact, most practices use 100% needles. It's a much quicker hookup, and it's much more efficient. However, you need to watch for burns, for infection, for excessive bleeding or hematomas, and also needle sticks. You got to be careful not to stick you or somebody else, and that does happen. You can use surface electrodes. It's mostly used in the clinical site, but you still can use them in the OR. We call them stickies. We also can apply electrodes with collodion. However, that practice isn't used that much anymore. The disadvantage to using surface electrodes in the operating room are the gels and paste that come along with these sticky electrodes can dry out. And if it dries out, then the stimulation becomes less effective, and then it changes your responses. Also, they sometimes, or often, they'll put a blanket warmer on top of the patient that keep them warm during surgery, and it can melt some of the gels. And if the anode, for instance, touches a cathode in a stimulation pair, it causes what's called bridging, and then the current shunts, and then you lose your SSEPs. Needles are most common, and they're better for the operating room. Recording electrodes. We use the 1020 system. However, Guideline 2 came out with a more current one in 2016 that allowed for more placement on the scalp. Some call it the 1010 system. We're going to be placing CP3, CP4, and CPZ, and FZ, or FPZ. We also place a couple on the shoulder, over the brachial plexus, one at C5, and the popliteal fossa. These are in the back of the knee. This 1010 system allows for more cortical representation, so you can place more electrodes on if needed. And it allows for modifications for evoked potential electrode hookup. A little tech tip: if you're hooking up before surgery, where some people do, or maybe even in the clinical setting, if you're hooking up C5, T12, the iliac crest, or the popliteal fossa electrodes, have the patient stand up or lay on their side and get them in first. And of course, you're not going to be doing this with them awake using needles. These are if you're using sticky electrodes. Make sure you use similar type recording electrodes. Don't mix metals, as to not introduce noise from the different potential charges that each metal possesses. You want to obtain low, equal impedances of all your recording and stimulating electrodes, and use twisted or braided electrodes to reduce 60 cycle, and that's electrical noise. Here's CP3, CPZ, and CP4. You also place FPZ, and some people say FZ because FPZ is on the forehead, and if they're using one of those BIS monitors, FPZ just gets in the way. Some people call it C3 prime, CZ prime, and C4 prime. However, prime was 2 centimeters back, and as the guideline says, we were finding that we weren't going far enough back to actually hit the sensory cortex or the post-central gyrus. So they have you measure C4P4, CZPZ, C3, P3, and we place the electrode halfway between each one, which is why they're called CP3, CP4, and CPC. P standing for the parietal lobe. C5 spine electrode, you have the patient bend their head forward, and if they're laying on the cart, this is a little harder to do, especially if they're supine. But if so, just reach your hand under there and palpate the most prominent spinous process, and that's typically C7. And you use your fingers to count 2 levels up. That's where you're going to be placing your C5 electrode. An alternate to C5, if they're doing a posterior cervical case, of course the incision's going to be there, so you're not going to be able to use the posterior neck. You can use linked ears. Place one at A1 and A2, jump them together as one into your head box. You can use the anterior cervical area, where you place the needle right above the thyroid cartridge. You can also use the lateral neck. It's the midpoint of the line drawn between C5 and the anterior cervical, so basically on the side of the neck. So we have the head electrodes on and we have the neck electrodes on, so let's do the shoulder. We're going to place an electrode on each brachial plexus, left and right. We call this Erb's point. This is the angle formed by the posterior border of the clavicular head and the sternocleidomastoid muscle. It's placed 2 to 3 centimeters above the clavicle or the collarbone. Now again, if the patient's awake, you have them shrug their shoulders forward, like you want one shoulder to touch the other shoulder. A triangular area kind of sucks in, and that's where you're going to be placing that electrode. Some alternatives to Erb's point, sometimes when you're doing anterior cervical cases, they don't want you in that area because that's where the incision is. So you can put the electrode posterior. It's farther away from the generator site, so the response isn't going to be as good. But you can also put it distal, and you can also put it in the cubital tunnel. The popliteal fossa electrodes, you find the crease of the knee, and you place one 2 centimeters above the crease midline, and the other one 5 centimeters above the crease, or 3 more centimeters proximal to the first one. Now some say even do it more, like 4 centimeters apart, for a better, more robust response. Now in the clinical setting, you're going to put a T12 electrode on, and sometimes we do that intraoperatively as well. If you need to put one of those lumbar potential electrodes on, we shoot for T12, and how to find that is you have the patient lay on their side, you find the top of the iliac crest, you go around to the back, and that's usually around L1, and then you try to count 1 spinous process up, and that's T12 right here. You're going to place the electrode there, and you're going to place a reference electrode on the iliac crest or somewhere around the hip bone. We also need to place a ground on the patient. We need to place it on the stimulating limb between the cathode and the first recording electrode. This is what best gets rid of stem artifact, which we will be showing you. Back in the day, this was connected to earth ground. These were the older machines. And the larger the ground, the lower current density if the current accidentally leaked. The larger the ground, the lower the current density, and the less risk of a burn for the patient. It's still today recommended to use a large ground. However, it's accepted to use a needle for a ground. Never ground more than once. This prevents a ground loop. And make sure your ground electrodes have a current limiting device. After the electrodes are placed, you want to make sure all the impedances are less than 5 kiloohms. And less than 3 kiloohms inter-electrode impedance should be attained as well. So it's important that they're equal as well as that they're low. Let's hook up the stimulating electrodes. This is what we used before we used 100% needles, are these bar electrodes. However, you do a case for 10, 12 hours and it's too much compression on the nerve because you have to tape this onto the patient. These are those sticky electrodes I was talking about. These are gel on the other side, and you have to rough the skin up a little bit and place those on. And like I said, with long cases as well, two things can happen. They can either dry out or the gel can kind of leak. And if you have one placed here on the wrist and one placed here, and this gel happens to meet each other between both of the electrodes, it's what's called a bridge. You can't record or stimulate if they bridge. It's important that stimulating electrodes also have a low impedance. So if you do use these, make sure that you're roughing up the skin a little bit, or one of these as well. The smaller the diameter of the electrode, the higher the current density is, which means the more intense burn. Increased current density means a more intense burn. Here's your surface area on a big pad electrode. Here's one on one of those sticky electrodes. And here's on a needle electrode. The larger diameter electrode spreads out the intensity, thus lowering the current density. Here's the brachial plexus. This is a plexus of nerves before it enters the cervical spinal area. It just shows the different pathways of the different nerves we're going to be stimulating. With the median nerve right here, if we're stimulating the median nerve out here, here's the action potential goes up here, and it actually enters the cord anywhere from C8 to C5, C6, C7. If we're stimulating the ulnar nerve, it definitely enters lower in the cervical spine. Here's the lumbar plexus. If we're stimulating the posterior tibial nerve, here's where it enters into the lumbar spine. If we're stimulating the perineal nerve, it enters a little bit higher into the lumbar spine. So where are we going to place these stimulators? We have a cathode and an anode. The cathode is where the initial neuronal excitation comes from. The way I remember it is a black cat is a negative thing. So it's going to go into the black input into your stimulator pods. It's called the cathode, and it's also negative input. We'll start with the median nerve. The cathode, again the black, is placed between the tendons of palmaris longus and the flexor carpi radialis muscles. It goes 2 centimeters proximal to the wrist. When you stimulate the median nerve, it causes a thumb twitch or a thumb abduction. You're going to need to know these actions. So the median nerve stimulation causes a thumb abduction. I know these got needles coming in them, but I thought it was a good picture of showing where the median versus the ulnar nerve is. So there's the median nerve. Here's the tendon of flexor carpi radialis. And here's the tendons of palmaris. If you have the patient make a fist and kind of cock their wrist forward, those tendons pop up. And that's typically where the median nerve kind of runs up. Here's the ulnar nerve. You got to be careful. There's an artery right here. So it's vascular there. So you got to be careful in placing those needles. The cathode, when you're stimulating the ulnar nerve, goes lateral on the wrist to the flexor carpi radialis tendon. When you stimulate the ulnar nerve, it causes a pinky flexion. Some alternatives to placement to the median nerve. Let's say you have a patient that's an amputee, or they have a cast on their arm or trauma and it's wrapped up and you can't place the median nerve stimulators. You place the anode medial to the cubital fossa, or the crease right here. So right midline there. And then the cathode will go 2 centimeters proximal to this anode. And you try to stimulate there. And this is somebody that a friend of mine recorded this. I thought was pretty good. Here's the Erb's point, but she's stimulating here instead of the median nerve down at the wrist. So these waveforms are coming in earlier because we're starting farther up the pathway. An alternative to placing ulnar nerve stimulation because of a wrist or an amputee or a cast would be placing the anode in the cubital tunnel. This is known as the funny bone. So it's more around the elbow, that little meaty, mushy part around the elbow that when you touch it, it kind of gives you a little tingling feeling. And then you place the cathode 2 centimeters proximal to this anode. If you're stimulating the posterior tibial nerve, you place the cathode halfway between the medial border of the Achilles tendon in the posterior border of the medial malleolus, which is the ankle bone. Here's your ankle bone, and there's the Achilles tendon, and the cathode goes halfway between this. Stimulation of the posterior tibial nerve causes a plantar flexion of the toes. If you can't stimulate at the posterior tibial nerve or at the perineal nerve, you can stimulate at the popliteal fossa. The cathode is the proximal electrode, and the anode is the distal electrode, proximal and distal with respect to the head. You can stimulate here and still record your SSEPs. Here's the perineal nerve. The cathode goes above the fibular head. Here's the fibula. It kind of goes above and a little bit behind it. If you stimulate the perineal nerve, you get what's called a foot eversion. The posterior tibial nerve is best to try to do an SSEP first. If you can't do that, you can do the perineal nerve. However, there's less intersubject variability in the posterior tibial nerve. There's a lot more leg movement in the perineal nerve as well. So if you have to use the perineal nerve, make sure you tell the surgeon that they may experience some leg movement and have them let you know if you need to turn the stimulus down. The red responses here are posterior tibial nerve SSEP. The green ones are from stimulating the perineal nerve. Now remember, you're stimulating halfway up the leg as opposed down at the ankle. So you're cutting off some time it takes to get those responses on the cortex. So that's why you see that shift. We talked earlier about saphenous nerve SSEP. So where do we put the stimulators? So the cathode goes in the groove between the vastus medialis muscle and the sartorius muscle in the medial distal thigh. You should be placing the anode and cathode about 1 to 4 centimeters apart, 10 centimeters up from the medial epicondyle. This epicondyle is this meaty place on the side of your knee. So the cathode's usually about 10 centimeters up here, and there's the anode, and this is where you stimulate the saphenous nerve. We talked about the cathode. That's what generates excitation of the nerve. And the anode to all of the cathodes are typically placed about 2 to 3 centimeters distal to the cathode. The anode is usually plugged into the red input of your pods, and it's a positive portion of the pair electrodes that you're going to use as stimulators for the SSEP. The black is negative, and then the red is positive. Anodal blocking is something that occurs if you switch the anode and cathode when you go to stimulate doing your SSEP. So remember that cathode should always be proximal, more towards the head. I've read in some publications where they don't believe this really happens, but I've seen it happen a few times, and this is actually one of my cases. This is the left side, it's an SSEP, and this is the right side. This patient was relatively healthy, so I couldn't figure out why they weren't producing a pretty good SSEP. This is my first run. This is actually 1 channel, 2 channels, the 3rd channel, and the 4th channel. This is that peripheral response, and then this is the subcortical response, and then 2 cortical responses. And you can see this first arrow, 3 and 4, the response just wasn't that good. So I did this a few times, and I thought, no, it just didn't seem right. I knew the patient was very healthy. So what I did is I switched the anode and the cathode on the right posterior tibial nerve. And look at this. Boom, it came back up. So I thought, well, I always have to make myself see it twice. So I switched it back, and I didn't get the response. And then I switched it the correct way, and then I did get the response. So each channel, you'll see the same thing. This is where the anode and cathode were switched. This is where they were in the correct position, switched, and in the correct position. And you can really see it in that peripheral response. You could barely see it in this first run, and then boom, this is in the correct position. This is the 3rd run, you can't see it. And then this is the 4th run is when they are in the correct position as well. This is called anodal blocking. It's important that your stimulator impedances are low as well. So if you're using surface electrodes, make sure you rough up the skin a little bit before you place those electrodes on. Now we're going to record the SSEP. To record, we first have to stimulate the nerve. We're going to talk about intensity, duration, frequency, and stem impedance. I'm not going to go too deep into this stuff because this is what David's going to do for you guys. Intensity is the strength or how much current or voltage you're delivering while stimulating the patient. Duration is the time that the stim pulse is in contact with the skin. The frequency is the rate at which we're stimulating, and the impedance of the stimulating electrodes needs to be low to decrease the chance of us having stem artifact. We're going to use monophasic rectangular pulses at a duration of 100 to 300 microseconds or 0.1 to 0.3 milliseconds. Now the intensity, that's where it gets tricky when these patients are asleep, and even further when they give them muscle relaxation, because you don't see the twitches anymore when you give them muscle relaxation. But if the muscle relaxation is worn off, you turn up the stimulator until you see a motor threshold, which would be twitching. And then you go 2.5 to 3 times above that motor threshold. 11B simply says, this is when you see these numbers here, that means the guideline. So guideline 11B means you should simply do 30 to 40 milliamps. But I've seen many cases where we've had to go higher than that. As we talked about, the peripheral responses are at the Erb's point if you're doing upper SSEPs, and they're at the popliteal fossa if you're doing lower SSEPs. Some say we need to stimulate, we keep cranking it up, especially if they're under neuromuscular blockade and we can't see the motor threshold. You turn the stimulus up until you see the amplitude, you see a well-formed either Erb's point or a popliteal fossa response. You turn it up more, and when that amplitude stabilizes, you know you're delivering enough current to get your responses. Some more stem parameters, the rate. We're going to stem at a rate anywhere from 3 to 7 hertz. Rates greater than 15 hertz can abolish the lower SSEP cortical responses. The slower rates can improve the lower extremity SSEP responses. For the upper SSEP, you can do faster rates. It doesn't obliterate the response, but it does make them messier and less reproducible. The guideline says use anywhere from 2 to 8 hertz. The faster the rate, the faster you turn over the data, but it does degenerate the response some. So it's a trade-off. Here's a lower SSEP that I did. Again, the left side and the right side, you got a peripheral response, subcortical, and then 3 cortical responses. This was me messing around with the rate. The red was using a rate of 4.7 to stimulate with to get these responses. I decreased the rate to 1.1 hertz and you get the green responses. And see how it improved the cortical responses? Didn't so much in this derivation, but it did in the second and third derivations, and even on the right side as well. The red wasn't so great, but when I decreased the rate, it kind of improved those cortical responses. So it's a little troubleshooting technique to try to improve your responses. The stem parameters while doing saphenous nerve are a little bit different. Because the leg is much meatier, you got to stimulate much higher. So you need to get your interpreting physicians involved in how high they want you to go in order to maintain patient safety. But some of the studies say they go 600 to 1,000 microsecond duration. That's hitting the patient pretty long at a rate of 2.67 and at intensity up to 100 milliamps. So you're hitting that patient pretty hard to get those responses. You need to watch for movement in the field because you are using higher intensities. This is what a saphenous nerve SSEP looks like. You've got a subcortical, and then you have 3 corticals. They're usually smaller in amplitude because the nerve is farther away from where we can stimulate. So it's deeper. If it's deeper, you're not going to activate it as well as you can in the wrist or the ankles. It's more susceptible to anesthetic changes than other SSEPs. In the literature, there's 81 to 97% success rate reported. I would say with us, it's probably 60 to 70% that we get them. Again, it depends on how heavy the patient is and whether or not the interpreting physician wants us to go that high in stimulation or not. You can stimulate in current or voltage. Most of the literature out there today expresses stimulation in current. Current is measured in milliamps. Of course, voltage is measured in volts. There's an approximate 1 to 4 relationship to voltage, so 1 volt equals 4 milliamps. The guidelines state to use constant current, and it's better for in the OR. It's important to know what interleaving stimulation is. We're going to be sometimes doing upper SSEP, both left and right side, and lower SSEP, both left and right side. Unilateral stimulation means you're stimulating only the left side or only the right side. Bilateral stimulation means you're stimulating the left side and the right side, but at exactly the same time. Interleaving stimulation means that you're stimulating the left side and the right side, but it's left, right, left, right, left, right, instead of both. So that's interleaving stimulation. That's what we need to be doing. The only time we would ever use bilateral stimulation, where you're stimulating the left side and the right side exactly at the same time, is as a last resort. You just can't get any responses. It's something you can try to boost cortical responses. However, if you do bilateral stimulation, know that you give up specificity because you don't know if there's a change, if it's really coming from the left side or the right side, because we're stimulating at exactly the same time. So it's important to know that interleaving stimulation and bilateral stimulation aren't the same thing. Bilateral is hitting the left and right at the same time. Interleaving is going left, right, left, right, left, right. And then unilateral is just left, 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 or right, 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 right. I hope that makes sense. Let's record the upper SSEP. I'm not going to talk a lot about filters or averaging or polarity because David's going to talk about that in his modules. But I will talk about filtering just a little bit with respect to what they do to the waves. A band pass is using a low frequency filter and a high frequency filter to filter out different frequencies so we get better recordings. Guideline 11B says we should use a low frequency filter of 30 Hz and a high frequency filter of around 1000 Hz. The low frequency filter at 30 Hz filters frequencies below 30 Hz. In essence, it blocks slow wave activity. But if we excessively use a low frequency filter, the waveforms can shift and appear earlier, and it decreases the latency. So what does that mean? Here's an upper SSEP. Here's the Erb's point, a cervical response, a subcortical response, and a cortical on the left, and then the same on the right. The red is the baseline, and it was done with a low frequency filter at 30 Hz. I changed the low frequency to 500 Hz, so we're filtering out a whole bunch of the slow wave activity, and that's what the green is. Look, it basically blew it away, the corticals and the subcorticals. It didn't so much the Erb's point because that's a faster frequency wave, but it did cut it at least in half. So excessively using the low frequency filter causes what's called a phase lead. Here's a better picture of it, and same thing. The red is the baseline, and it's using a low frequency filter of 30 Hz. I changed it to 100, and that's the green responses. And you can see how it really cuts down the slow wave activity and it just obliterates the waves. This is called a phase lead when you excessively use a low frequency filter. And the same thing with the high frequency filter. The guidelines state that you should use a band pass. A band pass means low frequency filter to high frequency filter. The interoperative guidelines say that you should use 1,000, but the clinical guidelines say use 3,000. For whatever you use, the high frequency filter filters out frequencies above wherever it's set. So it blocks fast wave activity. Excessive use of the high frequency filter makes the waveforms appear later. It increases the latency. Here's an upper SSEP. You've got Erb's point, cervical, subcortical, cortical, left side, right side. The red was done at a high frequency filter of 2000 Hertz. I changed the high frequency filter to 100 Hertz. And you can see how it just shifted out those waves and flattened them out. Yeah, they look a little prettier. You don't have all this jaggedy stuff in them. However, you're giving up amplitude and you're giving up latency when you mess with the filters. This is a little bit of a cleaner one. Here's the red again is the baseline with the high frequency filter of 200 Hertz. I changed the high frequency filter to 500 Hertz. Now, some of the guidelines say that to use a 500 Hertz, it does clean up the waves, but look at that shift in latencies. And it even decreases amplitude as well, and specifically more in the peripheral responses. Excessive use of a high frequency filter causes a phase lag. These latencies lag behind. Excessive use of the low frequency filter is a phase lead. And again, excessive use of the high frequency filter is called a phase lag. A couple of types of evoked potential responses. You've got a near field versus a far field response. The near field response is a response that's generated close to the recording electrode. The response has limited distribution and the amplitude decreases as the electrode is moved away from that generator site. A far field response is a response generated distant from the recording electrodes. The response has broad distribution and the amplitude may or may not decrease with electrode movement. They're acquired by volume conduction. So we'll talk more about this here as we talk about the individual responses. Right here is a good publication that really breaks down near field versus far field. And you can get that off the F.ASET website. You can have a stationary response. A stationary response is where the latency is unchanged despite where you have that electrode. You can change the position of the electrode up or down the pathway and the latency does not change, but the amplitude does change. In the upper SSEP, the cervical response is a stationary response. In the lower SSEP, that thoracic or that lumbar potential is a stationary response as well. A propagated response is where the latency does change when you move the electrode up or down the pathway. The amplitude may or may not change, but the latency will. In the upper SSEP, that Erb's response is a propagated response. In the lower SSEP, the popliteal fossa is a propagated response. Here's the montage for an upper SSEP. A montage is a group of paired electrode derivations. A derivation is a pair, and a pair records a channel. So this is the cortical channel, this is the subcortical channel, this is the cervical channel, and this is the Erb's point or the peripheral channel. Again, a pair of electrodes is a derivation. We're going to start with the Erb's point. The Erb's point we call N9. You're going to see N with a number and you're going to see P with a number. N stands for negative, P stands for positive. The number generally stands for how many milliseconds we expect to see it in a normal patient. So the N9 is a peripheral response. We also call it an Erb's point response. It's a triphasic response. I'll show you why we call it that in a second. It's also a propagated response. It's propagated because we can move the electrode and it'll change where that latency is. It's also affected by how long the patient's arm is. The longer the arm, the longer the latency. This peripheral response proves the integrity of our stimulators, of our machines. So I believe this is one of the most important one to get, to be honest with you, because it proves that my machine is working accurately. It's also a near field potential. Why? We place the electrode over the brachial plexus. That's exactly what's generating the response, the brachial plexus. So it's a near field response. By triphasic response, I mean the response theoretically crosses the baseline 3 times. That's what's called a triphasic response. This Erb's point response is generated by ascending nerve fibers of the brachial plexus. We stimulate here at the median or ulnar nerve. That action potential conducts up, and we have the recording electrode at the brachial plexus, and we record this nice N9 response. The N9 response comes from the ipsilateral Erb's point electrode. That's the active electrode in the derivation to record the peripheral response. The N13 response, or the cervical response, is a stationary response. The latency will be the same regardless of where you place that cervical electrode. It's a negative response. It's also near field. We have the electrode placed at C5 spine, and that's where the response is generated. The N13 response is perfused by the posterior spinal artery. The generator of the N13 response, or the cervical response, is postsynaptic activity from the cervical cord. This is an example of what the N13 looks like. We stimulate at the wrist. We record through the brachial plexus up into the cervical spine. That response is being generated by the cervical spine where we have that C5 electrode placed. This is an example of what a stationary response looks like. We're doing an upper SSEP, and I have an electrode placed at C2, C4, C5, C6, and C7. We also have it placed at the lateral neck, the anterior cervical area, the chin, and C5 and C7 over on this side of the screen. So let's talk about the left side of the screen first. The stationary response means it's maximal in amplitude at C5. However, if we move the electrode up or down, you see the latency doesn't change, just the amplitude is. That's called a stationary response. Over here on the right side of the screen, just wanted to show you the difference between those alternative placements. C5, this is our normal placement of the C5 electrode. Again, C7, you're going to have a lower amplitude, but the latency isn't going to change. The chin, the anterior neck, and the lateral neck may have an inverse polarity, but the latency again will not change, proving that this is a true stationary response. The first component of the subcortical response is the P14 response. Now this is a far field potential. The P14, or the subcortical response, is perfused by the basilar artery. Then N18 is the second component of the subcortical response. It's a negative response, also a far field potential. It's recorded by using a scalp to non-cephalic reference. We'll talk about that in a second. The guidelines suggest that this response is being generated from the thalamus, but it's generated nonetheless the upper part of the brainstem. Again, perfused by the basilar artery. Here's the P14 and the N18. That's a far field response. We're using the ipsilateral cortex, ipsilateral to stimulation, or the same side, and referencing it to the contralateral Erbs. And we're picking up that brainstem response. Again, here's the derivation of electrodes, the ipsilateral cortex in the contralateral herbs. It picks up this brainstem right here, this response. The electrodes are farther away from the generator site, which is why it's a far-field response. The generator of this P14 response is the caudal medial lemniscus, or the bottom of the brainstem. The N18 generator is postsynaptic activity from the top of the brainstem. And again, some say the thalamus. We're recording, we stimulate the wrist, we go through and record the N9, the N13, the cervical response, P14 and 18 subcortical response. The subcortical response is using a non-cephalic reference, or a reference that's not on the head. Some say you can use the elbow, the hand, the knee, or the ankle. We use the Erb's point electrode. So we're using the ipsi cortex and we're referencing it off the head to the contralateral Erbs. On to the cortical response. The N20 response, it's a response of the primary sensory cortex. It's a negative response, and it represents activation of the somatosensory cortex. It's a near field potential, and it's perfused by the middle cerebral artery. The cortical response is generated by the contralateral, to stimulation, post-central gyrus. We stimulate at the wrist, we go through the N9, the cervical response, the brainstem, and it projects out to the cortex where we have that electrode there waiting to record that N20 response. This P23 response is just the second component of this cortical response. The active electrode in this derivation is the contralateral cortex. And again, it's contralateral to stem. We're stimulating the right side, but we're recording the left cortex. This is from the ACNS. Just points out the different responses, and then there's the pathway. Stimulating the median nerve. The peripheral response is N9 from the peripheral nervous system. Then it enters the central nervous system where you get the cervical, the subcortical, and the cortical response. And this is what it looks like. The ACNS recommends an extended montage for SSEPs as well. Depending on where you guys go to work after graduation, they may use different variations to do their upper and lower SSEPs. And this is another one. This is using two corticals, but there's your Erb's point, your cervical, your subcortical, and then two cortical derivations. Left side and right side. These are very pretty. I did these. Let's record the lower SSEP. This is what a lower SSEP looks like. The peripheral response, the subcortical, and then two cortical responses. We're going to stimulate at the ankle, and we're first going to record the N11, which is the popliteal fossa response. It's a negative triphasic response coming from the peripheral nervous system. It's a propagated potential, meaning the latency is affected by the length of the leg, or the latency is affected if you move the electrodes. This peripheral response also proves stimulator integrity, so it validates stimulation. It's a near field potential. We got the electrodes right over the popliteal fossa valley, and we get the response there, so it's near field. And it's perfused by the femoral artery. Here's what the popliteal fossa response looks like. It's generated by ascending fibers through the popliteal fossa valley. We stimulate at the ankle, and right there we record. These are placed on the back of the knee. It's generated by the proximal electrode referenced to the distal electrode. Now you're not going to be doing this lumbar potential very often. Sometimes you will, maybe if you monitor a hip surgery. But this is the electrode we placed at T12. It's a negative response recorded from the central nervous system over the thoracic spine. It's a stationary response, meaning you can place it at T12, T11, T10. And no matter the placement, the latency stays the same, but the amplitude will be maximal at T12. It's a near field potential because we have that electrode at T12, and that's exactly where the response is coming from. Some say this response is analogous to the N13 response of the upper SSEP. That's a stationary response as well. Here's what the N20 or the lumbar potential looks like. It comes in around 20 milliseconds. So we're recording at the ankle, through the popliteal fossa, and right there is where we record that potential. It takes about 20 milliseconds to get there. There's the iliac crest electrode, which is the reference. The active electrode is T12. Reference is the iliac crest. Some places will have you do an epidural electrode. This is a near-field response. They're placing an electrode right on top of the dura, under the laminar arch. Then it's sutured in for security so it's not pulled out. It's a very stable response and it's unaffected by anesthesia. It's usually artifact-free as well because there's no muscle activity to get in the way. The disadvantage, though, to recording this is that you can get an asymmetric response if it's not laying directly on top of the dura. It's also a blind placement, so you have to trust the surgeon to put this in there. It also will increase the length of surgery as well. The reason I put this in there because historically this has been on the CNIM exam. I don't know for sure if it is still or not, but I always throw the slide in there. The electrode that was used in this publication called Up and Down the Spinal Cord was composed of 2 platinum buttons on a Teflon sheath. The buttons were 0.40 centimeters squared and 8 millimeters apart. They were platinum to avoid toxicity if we should happen to stimulate with this electrode. This is what the recording looks like right here. It's a multiphasic, very reproducible response. The filter settings or the band pass, low frequency filter of 30, high frequency filter of 500. And this particular recording was recorded at a stim rate of 23.4. Let's go on to the subcortical response in the lower SSEP. The P31 is the first component of the subcortical response. It's a far field potential. It's FZ to a non-cephalic reference. We typically use C5. C5 is off the head. The subcortical response or the brainstem is perfused by the basilar artery. Some say that this P31 response is analogous to the P14 response in the upper SSEP. They're both the first component of the subcortical response. The second component of the subcortical response is the N34. It's referentially recorded from FPZ reference to C5 or a non-cephalic reference. Again, the second component of the subcortical response, it's a far field potential because we're using these electrodes that are not close to the generator site to try to pick up the brainstem response, perfused by the basilar artery. And some say that the N34 response is analogous to the N18 response in the upper SSEP. The P31 generator is postsynaptic activity from the caudal brainstem. The N34 portion of it is the rostral brainstem. The N34 represents postsynaptic activity from the rostral brainstem. It's being recorded by FZ, reference to C5 and non-cephalic reference. I'm going to stimulate at the posterior tibial nerve, record through the popliteal fossa, through the lumbar potential, up through the brainstem. Now you'll notice the lower SSEP does not have a cervical response. This is a brainstem response that just happens to be referred to the C5 spine electrode. So that's used as a reference. This is not a cervical response. This is a subcortical response. There is no cervical response in the lower SSEP like there is in the upper. It's a different pathway. Let's go on to the cortical response. The P37 response is a positive response, comes in usually around 37 milliseconds. It's recorded by using 2 electrodes right on the scalp, so it doesn't pick up the subcortical response. It cancels them out. It's a near field potential because we place the electrode on the postcentral gyrus, and that's exactly where the response is coming from. And it's perfused by the anterior cerebral artery. And as we mentioned earlier, the amplitude can attenuate up to 80% if you use a stim rate greater than 15 Hertz. And that's with the lower SSEP. We usually do 2 cortical responses because that response is maximal anywhere between midline and ipsilateral to stimulation cortex. The generator of the P37 or the cortical response is the postcentral gyrus or the sensory strip. stimulating at the ankle, through the popliteal fossa, lumbar potential, up through the brainstem, out to the cortex. It's generated anywhere midline or CPZ to CPI or ipsilateral to stimulation cortex. And here's the ACNS picture. They didn't have the popliteal fossa in there, so I drew that in there. So here's the popliteal fossa. There's that lumbar potential that we record at T12. Here's the subcortical response. Here's the lower component and the higher component of the brainstem. That's that yellow area. That's the brainstem. This C5 electrode is used as a reference to record that. Then you have two cortical derivations, one using CPZ and one using CPI, or the ipsilateral cortex, to record two cortical responses. Here's an extended montage for the lower SSEP as deemed by the ACNS. You may go to different practices that might have different recording montages. Here's a lower SSEP. This is another one that I've done. Popliteal fossa. The subcorticals are usually pretty small because remember they're far field potentials. We're taking two electrodes and trying to pull that brainstem out by referencing those two electrodes together. This particular montage has three cortical derivations. One recording at CPI, or the ipsilateral cortex. The other one at CPZ, and it's referenced to the contralateral cortex, and the third one at CPZ, but it's referenced to FZ. There's the left side and then the right side. Lastly, let's talk about criteria for alarm. When do we alarm the surgeons? First, we need to ensure that all the obligate waveforms are there. Obligate waves are waves that are just that. They're obligated to be there. In the upper SSEP, N9, N13, P14, N18, and N20 all must be there, all must reproduce. They're obligated responses. In the lower SSEP, the lumbar potential, if you're doing it, again, it's rare that we do it, but it's in the guidelines, so if we do the lumbar potential, it's obligated to be there, obviously, or the popliteal fossa if we're not doing it, the N34 and the P37. In the lower SSEP, these all must reproduce, and they're all obligate waveforms. Criteria for alarm, obviously, is when they aren't there. So we're going to warn the surgeon if we lose any of these responses. Also, we don't only look at whether they're there or not. We look at their latencies, and we look at their amplitudes, and then we look at the inter-peak latencies, the time it takes to get from the N9 or the Erb's point. How long does it take to get from Erb's point to the cortex? How long does it take to get to Erb's point to the subcortical response or the brainstem? And how long does it take to get from the brainstem to the cortex? We look at that time in between there and determine the baseline. And when it changes from baseline, that's when we alert the surgeon. The same thing with the lower SSEP. We look at the popliteal fossa or the lumbar potential to the cortex, the popliteal fossa or lumbar potential to the subcortical response, and the subcortical response to the cortical response. When the time it takes to get between these 2 points increases, that's an increased interpeak latency, and that's criteria for alarm. That's when we need to tell the surgeon. Typically, a 50% decrease in amplitude and a 10% increase in latency is considered a significant change in the SSEP. That's when we start warning the surgeon. But as I mentioned earlier, we want to look at those interpeak latencies too. We also want to look at the left side compared to the right side, or the intertrace latency differences, the left compared to the right. If one is changed more than the other, of course, that's a criteria for alarm, and we should alert the surgeon. If there's a 30 to 50% decrease in intertrace amplitude.